Good morning. I think we had an extensive talk by Dr. Andrews. I will be talking about spectacle intolerance. I will be going through the few of the problems. Spectacle intolerance, whether we accept it or not, it is a very common thing. Some of the patients will come and tell you, after you prescribe a glass, they will come and tell you that my earlier spectacles was better. Actually, this is a big insult. Then you will have all sorts of problems. Once you start using more and more progressive lenses, the intolerance also is increasing. What are the causes of intolerance? Refraction problems, dispensing problem. You'll see that there is a communication problems comes as a 30% of things. So you should explain to the patient what type of lens glass you are prescribing and what are the problems patients going to face it. There is minimum, there will be around 6% of the patients will be unhappy. Patient sometimes won't like the frames or lenses. Near vision correction, that is the main problem. Sometimes it will be too high or too low. Frames usually won't fit. Sometimes it will be allergic and fogging of the lenses. All these problems. How will you prevent it? The good history taking is again important in here also. Occupation is very important. Some carpenters or priests and all, they requires at a near vision at a more distance place. And careful refraction is most important. End of the refraction. Every time you should instruct your refractions or yourself to check whether the new refraction or the present glass is better and discuss with the patient whether you have to change it or not. Don't force the patient for every 0.25 change. IPD measurement is a very important point in fitting the lenses. A distance between the nasal border of one pupil to the temporal border of the other pupil. More importantly, we have to think about PD. Actually, it's not the IPD. From on many patients will have a different distance for each eyes. Use corneal reflex pupillometer or strabismus eyes. You have to occlude one eye and record the things. Frames must be comfortable. Lenses should be perpendicular to the visual axis. Bridge sizes should be ideal. And the frame should not rest on the apple of the cheeks. Then the patient will have a lot of problems. Should not cover the eyebrows. Round frames, that is not that common nowadays, like Gandhi frames. If you are using astigmatism or a cylindrical power, it can rotate. Vertex distance should be very important, especially in high errors. Try to fit the lenses at the anterior focal point. Should be large enough to give good visual field. Vertex distance should be same as like in the trial lens. So as Dr. Andrews mentioned, high index lenses are good for the high refractive errors. Anti-reflection coatings and all extensive things he has covered up. When you are thinking about bifocals and progressive, then you will have all sorts of problems. And we have to tell the patient how the lenses are going to work. The image jumping, that is a main thing. Whenever you start prescribing first time progressive or a bifocal lenses, the first complaint patient will come and tell you is the difficulty to walk. So you have to explain to them what is going to do. This picture already Dr. Andrews has shown that there's a very good understanding of how a progressive lens works. And most of the time, actually, we ophthalmologists should understand how a progressive lenses works, and different models works in a different way, and we should know how it works, and we should explain to the patient properly. Who are all the best candidates for progressive lenses? Those who are already using progressive lenses, first-time presbyopic wearers, highly motivated people. Difficult people are high ad powers, previous wide segment bifocal wearers, they never will be happy with your progressive lenses. Individuals sensitive to vertigo or motion sickness. Some individuals are very sensitive to changes in the vision. Selecting the frame, whenever you are using progressive lenses, the market they will be telling that you can fit it for even with the 20 millimeters, but you have to be very careful. Minimum of 25 to 30 millimeter will be, patient will be comfortable. Otherwise, patient will have a lot of problem with the progressive lenses. And these are all the things you have to be very careful. Pantoscopic tilt. That is a tilt which refers to the frame alignment in the up and down position of the frame. Pantoscopic means lens bottom is rotated towards the cheeks. If it happens or if it is vertically, then it will have problems. So whenever you have a pantoscopic tilt, you have to consider that particular patient's ear height also. Some patients will have a ears positioned up or positioned down. So you will have a measured pantoscopic tilt. But effective pantoscopic tilt can change according to the ear position. So whenever the patient comes back with some complaints, you look at the ear position and how, whether it's a pantoscopic tilt is more or less. Again, this, why we want the pantoscopic tilt? You can see that this is the reason by which you recurse, because if it is vertical, you cannot see the lower part properly. So you recurse a pantoscopic tilt to see. And inadequate pantoscopic tilt can reduce the effective size of the near zone. So if the patient comes back with a problem in this thing, you can measure this pantoscopic tilt with this type of measurement which is available. So you can measure how much is the tilt practical. You can measure it with the frame in your hands, or you can measure it with while patient wears this. So ideally you have to measure it when the patient wears it. Then only you can see the actual pantoscopic tilt. The vertex distance, again, it is very important. If it is very far or very close, then the whole refraction will be changing. So vertex distance, whenever the patient comes with some problems, you have to measure it. It is very simple to measure it. You ask the patient to wear it, you measure it, what it is, the vertex distance, and you correct it. So most of the time you have a habit of just checking the power of the lens only. That is why so many times the problem happens. About the face form wrap, again, our face is round, it's not vertical. So you should have a lenses rotated like this. Then otherwise the patient's field will be difficult and the magnification will be different. And again, you have to see that health tilt. Some patients will have some health tilt. So you have to, whenever the patient comes back with all this type of intolerance, you have to check whether there is a health tilt, because these are all will change your all fitting things. And optician, when they take some measurement, most of the time the patient will be sitting, the optician will be standing and taking the measurement. So you have to be very careful. So even a slight 1 inch height difference will make 1.7 mm of error in that physics. So you have to, the patient as well as the optician should have eye position in a parallel way. So already Dr. Andrews has mentioned about different computerized systems to measure and fit the lenses. The Visioffice is one of the SLR system. Visioffice 2 is now available with this thing. So it makes the opticians to do all these measurements in a better way and in an easier way. There is not much a problem to fix all these things. Effect of incorrect PD measurement is huge in cases of progressive lenses. If it is not correct, you know that this central area intermediate zone is very small. So the patient will have all sorts of problems, distortion through this area. So you have to see that the measurement is correct. Effect of residual cylindrical power, uncorrected astigmatism. Sometimes you will be neglecting some astigmatism, or sometimes you will be adding some unwanted cylindrical power. Both can distort the vision too much in a progressive lenses. So we have to check the refraction correctly. We have to see that whether it is corrected properly. And you have to think that some patients who are using progressive lenses, you will be adding powers. So now first year it was +1, then you will be adding +2 or +3. Then the patient will tell you that I was using progressive lenses for all these years, but I was not having any problems. So you have to explain to them, even if the refraction and optician is fitted correctly, patient will have a little more problem when you add it more. So if there is an astigmatism also, then the problem will be increase. So Dr. Andrews has already mentioned about the hard design and the soft design. So hard design, if the patient was using a progressive lenses with a soft design, the patient next time if he is going and purchasing a lens with a hard design, then patient will have all sorts of problem, because he won't tolerate, because the central zone is the one that this zone will have a sharp changes. So patient will have all sorts of problem. Patient will be telling that I was using progressive earlier also. So, but you have to identify what type of progressive patient was using earlier and what type he is using now. If the patient was using a hard type earlier and switching over to soft, they will be comfortable. But if it happens in the other way around, then it is a problem. Correction of astigmatism is very, very important, but children can tolerate high cylinders. Anisometropia and aniseikonia, as I think this part everyone is aware. So you have to be careful about this, and we have to explain to the patient properly. Base curve, you should be very careful. Whenever the patient comes with a progressive lens, we have to verify whether refraction is correct or not. We have to see that whether add power is, whether the patient needs are, or occupational needs are correct for this particular prescription. Verify the prism, both wanted and unwanted prism. Verify fitting heights to pupil center and the lens center. Verify monocular interpupillary distance. Verify frame adjustments including tilt, wrap and vertex distance. So there is a lot of work when you are prescribing a progressive lenses. Should be fitted correctly, and our responsibility is, you have to think that whenever the patient comes with a minimal changes, we have to discuss with the patients. You don't force the patient for any change. Then definitely the patient will come back with a lot of problems. If the patient asks for a change, then it is much comfortable. Patient will tolerate. Otherwise, patient will come with even small problem, he will create lot of problems. Give same base curve as before, and this is the one thing we won't be checking it every time, but you have to have a good optician with you for all these things. Stiffer base curve for lash clearance to be avoided, as it will cause image magnification. High minus specify high index lenses. Avoid very large frames or very small frames. Proper counseling is a very, very important. As I shown in my earlier slides, 30% of the patients are unhappy due to not explaining the difficulties or the problems of all these lenses. So never assume a hostile attitude is complaints. If the patient comes back with a problem, most of the time he will be right. And we have a tendency to tell, so everything is correct. Don't take it like that. If the patient comes back with a problem, he is having a problem. So only thing is you are not finding out the problem. So you should have an open mind to find out the problem. Thank you.